Thank you. It's kind of, I guess it's our third year here, and there's often time I sit, and as you know, I see a lot of women with PCOS, and it's very frustrating. You sit there, and many symptoms are, hair growth and struggle with weight and diabetes and other things, and then I think to myself, well, I've been doing this for so long, but do I really have anything to treat this individual in front of me? And oftentimes, I don't. We just kind of have a variety of some medications, birth control pills, but I think this is a great conference, because a lot of times when you meet somebody that has some of the same symptoms you have, it's better to talk to them than to see a doctor who just keeps giving you on the same thing and doesn't really know exactly what's wrong with you, or doesn't really know how to fix it. And so it's wonderful to see so many of you here, and I commend you for coming here and spending the time with us. All right, so I guess I was asked to say update. Well, it's difficult to have an update because maybe sometimes there's not a lot new going on. But I kind of wanted to give a little bit of overview to kind of try to put everything together for you. And so, well, people ask me, okay, but they say I have PCOS. Do I really have PCOS? I don't really have hair growth. I have regular cycles. And what are you guys talking about? I don't have PCOS. Can you tell me if I do? Well, the problem is we call it a syndrome, and the reason we call it a syndrome is not every person has the same thing. Some women have excess hair, some women have irregular cycles. Some women have more issues with just hair loss. Some women have infertility. What we do is we try to lump all these things together, and it's sometimes not perfect. And most recently, as of last year, the society is struggling to call it polycystic ovarian syndrome, but it's not really cysts. So women come to me, she says, oh, doctor, I had cysts. Well, it's really not cysts. These are ovaries that are just having follicles or eggs, and there are several of them, and they're not real cysts. These are just eggs that are just not getting to be released every month. So really, we're struggling with the name right now, but it's just not the name we have to struggle. We have to struggle with what's going on here. It's not really cysts. It's an ovary that's producing extra amount of hormone, and it's affecting everything else. So if you kind of have to have two of three things, either irregular cycles, elevated male hormone in the blood, but then you get a blood test and it's testosterone and it's normal, just like the first speaker, what do you do? Well, it's not, we don't really measure testosterone very well. You really have to distill it, and it takes several hours to do, and none of the labs do those things. So if I have a woman and she comes with a beard and she says, what are you telling me? I have a normal testosterone in my blood, and why do I have all this hair? Well, I'm sorry, but those tests are not very good tests. We don't have great tests to measure testosterone in the blood. But if it's elevated, or if there's extra hair here, particularly in the chin, on the nipple, or underneath the belly button, those are areas that women should not have hair underneath their belly button. It's more of a men kind of phenomenon. And so if you look at the ovaries, so the ovaries is typically enlarged, and we see more than 12 eggs. Those little black areas are where the eggs are. And so we have more than 12 eggs. We call it PCOS, but sometimes women have more than 12 eggs in the ovary and they don't have PCOS. But if you have to have two out of three things, elevated male hormone in the blood, extra hair, irregular cycles, or ovary that looks like this, two out of those things we call it PCOS, okay? Now, there's also variation in ethnicity, so it's not the same people from the US are not going to be the same people from China. So women from South Asia and Hispanic women have more issues with, like, the blood pressure, the high cholesterol. They have more issue with the abnormal glucose and the diabetes. We take African American women have more issues with high blood pressure, and heart disease is more common. The interesting about heart disease now, women go into menopause where they don't have a cycle, their male hormone goes down because ovary is not working anymore, and now they have heart problems. So now they're finding out that women that have heart disease actually had PCOS and never knew about it. And now they're measuring their testosterone, they're in menopause, and testosterone could have been high from a long time ago. So more and more is coming out about women older women now, they're in their 60s and 70s or developing diseases, actually had PCOS when they're younger and they should have been treated, okay? And if you look at Eastern European, their sugars is not really as bad as other women like Hispanics, okay? And so we talk about insulin resistance. What is this insulin resistance? You know, they said, look, doc, they do my sugar all the time, it's normal. All the time, every time they check my sugar, it's normal. I don't have PCOS, my sugar is always normal. Well, we're talking about insulin resistance. What does that mean? Insulin resistance means you're not diabetic. If I do a regular blood glucose, it's going to become normal. But what it is about 50 to 70% of women have it with PCOS. It's just that the liver, the fat, cannot use glucose like it should, okay? So when the body insulin has to bring the glucose into the cells for us to use, because our brain, our muscles, our cell all use sugar. Insulin doesn't do a good job. So when insulin doesn't do a good job, the body wants to make more of it. So the body makes more insulin. So you have extra amount of insulin. That's called insulin resistance. It's just not working like it should, okay? And so it has to, insulin stores calories and also makes fat. So if you have more of something that makes fat, that's really bad because it makes fatty acids. It actually makes fat. It stores our glucose. So anytime we eat, it stores glucose so we don't starve in between meals. Okay? And so the problem is that when it stores fat, well, it creates more obesity. Okay? And so the other issue, not that only it stores fat, it also makes more testosterone, which makes things worse for everything else, excess hair, regular cycles, and so forth. So we think that if you think of PCOS, think of one big issue, that's insulin, okay? It's just not working the way it should. All right, and so here's our biggest dilemma. Women should have the pear shape on that side. We don't want women to have the apple shape, meaning that more weight up here above the waist and less weight in the hips. So we prefer if women have hips but don't have a belly, okay? A belly is more of a man's problem. They should have the belly, not the women, okay? So when women have belly, that's a big problem. That's a huge, huge problem, and it's an increasing problem, to say the least, because when women have more of a belly, they have more insulin resistance. Their insulin doesn't work very well, okay? Just like men. And they may develop problems like men, like high blood pressure, like diabetes, like, and this is like an endocrine organ. So when women develop more of a belly, that's more of a problem. They develop more problems like men when they shouldn't, okay? So we always try to go to this, the pear shape is much better than the apple shape. So when I ask women, I say, well, doc, you know, I've been trying all this thing, I'm not losing a single pound, but, so then I ask them, well, do your clothes fit better? Why, that's more important to me, because if their clothes start to fit better and they need a smaller size clothes, that's much, much better than the actual weight loss per pound. Because when you weigh yourself, you're weighing muscle, you're weighing fat, everything is on the same scale. But if the clothes start to fit better, that's a huge, huge solution to some of the symptoms, okay? All right, so here's the problem when we make extra amount of insulin, okay? If we have a family history, if the mom had diabetes, well, that makes things even worse because that individual will have a much higher risk of developing diabetes if she has PCOS. And so for family history, and then that individual did very well in college, and all of a sudden after age of 25, weight starts to go up, and all of a sudden she just gained 20 pounds in a year, and that's very common for us. They gain weight very quickly. Or after a meal, you haven't eaten very much, and all of a sudden you're 2 to 3 pounds heavier. That's an issue because those things will start causing the sugar not to be absorbed very well because insulin's not working very well. So all of a sudden, the blood test goes higher and the sugar, instead of being less than 100 in the blood, it becomes to be 105 or 110. And slowly but surely, that sugar will go up gradually and that individual will develop diabetes. So as a woman gets older, insulin doesn't work very well, sugar goes up. Within a few years, they can develop diabetes. And oftentimes it worries me because I have women I'll see her and I say, you know what, her sugar is 102, 99 was normal, it's not a big deal, I'll just have less carbohydrates. The next time I see him, he goes a little bit higher, and I said, well, have you taken some of the, have you done the diet, or have you taken metformin? And she says, you know, I couldn't, metformin was making me sick. Within the next 6 months, I might see her, her sugar might go up to 120. If it goes up to 122 and higher, she's diabetic. If it goes up above 122, I lost all my effort. I have a hard time bringing them back to be normal. Because what's happened is as the body makes more insulin, the cells in the pancreas will continue to work, and they work harder and harder again and again. They start to burn. And then that individual who's making so much insulin before, all of a sudden can't make any more insulin, and the sugar starts to go up, and then we label them as diabetic. So it's like of a progression. You make more insulin, it keeps going, age, obesity, everything contributes, and lo and behold, it could be 2 or 3 years later, the individual's diabetic. So we try to get them in early, we try to catch them. And oftentimes patients, you know, I look at myself, I said, am I really doing too much? But I'm not, because if I got that individual early and I just bombard them and say, hey, you gotta watch your diet, watch your carbohydrates, take your medication, try to do these things, because you don't want to be like that person who comes to me and she's 35, 36 years old and she takes a blood pressure pill, she's taking metformin, and she takes a cholesterol pill. Well, these things could have been solved much earlier, okay? All right, so I was talking about insulin. So look, insulin's doing all these things, all these things. More testosterone means more hair growth, okay? More testosterone also means less lack of ovulation, so there's less cycles. There's no cycles because we're not ovulating. There are plenty of eggs in the ovary, but they're just not growing, okay? So when a woman does not ovulate, she's not gonna get a cycle. You must ovulate to get a cycle. And some people say, okay, but I have a cycle, so what are you telling me? Well, that's because the lining in the uterus got so thick, it just broke. It doesn't mean you ovulated. So you could still have a cycle and not ovulate, okay? So, of course, there's more triglycerides. If you look at the blood test, if you ask your doctor, hey, look, what is this insulin resistance? Measure my triglycerides, because oftentimes, remember I was telling you insulin makes fat? So if you just measure the triglycerides and the woman is 120 pounds, she should not have high triglycerides. That's coming from insulin resistance. That means that insulin is making the fats and making triglycerides, okay? That's just like cholesterol. It's just as bad. And then the insulin can actually cause high blood pressure. Insulin makes the vessels contract. They're not elastic. They don't dilate as well, and it causes them to have blood pressure, okay? And at the same time, the high insulin, the blood pressure will cause the heart disease. And that's like the one thing we cannot do. All right? And so the testosterone so testosterone is coming from the ovary. We know that that's causing a problem by itself. Insulin resistance is out there, so testosterone is there. So we kind of got two different things going, not really different. One contributes to the other, but they're both causing more problems, okay? And so in infertility, the more testosterone from the ovary and the higher the insulin resistance actually cause the egg not to develop very well. So we have lots of eggs, we can grow them, but they don't develop very well. I do IVF, I get 25 eggs from a woman, but by the time we grow them and make embryos, we end up with four embryos instead of getting like 15, 16 embryos, which I usually get in a normal woman. That's because the eggs are not developing very well. Somehow they're not dividing as should. So all these hormones are causing problems with the eggs. They're causing problems with development. They cause problems with infertility. Okay? So when you think about it, it comes down again. Insulin resistance is contributing to obesity. That makes ovulation worse, and that causes infertility. So women, I get mom bringing their daughters in, and she's like 16, 17. She says, you know what, she's having same symptoms that I do. I want to make sure she doesn't have any problems. I want to make sure she can have children as she gets older. Well, think about the one good thing is this. Women with PCOS are not really infertile. Get that out of your head. Women are not infertile, because otherwise we won't have 7 to 10% of them every year, and it keeps growing. They'll be infertile. They'll have 2%, 1%, 0.5%, and that's it. So women with PCOS are fertile. The problem is they don't ovulate very well. And they don't ovulate very well. Yeah, it's difficult to achieve conception, but once they ovulate, they're just as perfect as anybody else, okay? So they are fertile, okay? Now, so what we do is we try to, our biggest worry is that when they're not ovulating, we try to always lower their insulin. Well, you say, okay, but she's a size 2, she's perfect, she looks wonderful, she's got PCOS, but how are you going to lower her insulin? She's not even obese. Well, it turns out that women who are thin and PCOS still have intra-abdominal obesity inside intra-abdominal fat, and they still have insulin resistance. Regular cycles, perfectly healthy, but they could still have insulin resistance. So one of the things that we try to do is we try to lower our insulin first, so we can lower their testosterone and get them to ovulate, okay? And then you could use Clomid, which we don't use so much. I don't like it very much. Letrozole, use in combination with metformin to try to get them to help them ovulate, because you kind of have to use more than one thing to kind of get the process going, get that egg to start growing. And oftentimes we have to go and use IVF, in vitro fertilization, because that kind of helps us grow the eggs, which are not, we're doing everything we can, they're just not growing very well. Or we try some medication, all of a sudden all the eggs are growing, and we don't want to have multiples. So all of a sudden all those eggs that have been dormant for so long are growing. Then we have to do IVF. We actually go in, take the eggs out, place them with the husband or partner's sperm, make embryos of them, and then just put 2 at a time so we don't get triplets, quadruplets, or so forth, which is a worry, okay? And so what we're doing now is when we do IVF, the nice thing we can do now is we grow the eggs, but as you grow the eggs, it makes a lot more estrogen, and then you can get ovarian hyperstimulation syndrome, where after you take all the eggs out, the ovaries keep on growing. The individual can get sick. So what we're doing is we take the eggs out, making embryos, and then waiting until all those hormones go away, the ovaries will shrink down, all the estrogen that we increase goes away, and then we're putting the embryos back into that individual. And that is more of a natural environment, and they get pregnant better, and it's healthier for that individual. And our pregnancy rates have gone up since we're not taking the eggs out, making embryo, and putting them back in right away. We just wait, let things calm down, let all the hormones that are out there go away, and then we put the embryo back in. So that's one of the things that we do now in women with PCOS, okay? And then, so the way we use metformin with PCOS because it kind of helps us lower insulin. So we talked about insulin was a problem, so we try to use something to help us lower insulin. And one of the way it works, it allows the glucose to go up into the liver, okay? And so it causes the glucose to go into the liver, into the fat, and then the liver doesn't make all the sugar that it needs to make when we're not eating. When the liver makes less sugar, then the pancreas will make less insulin. So we have less insulin with metformin. So we lower insulin with metformin, we lower testosterone, and it does help us with increasing ovulation. Okay? And so I have women that come in and then their blood tests, all the liver tests are all of a sudden elevated, and the doctor's I have women that go in and liver tests are elevated, and the doctor does a biopsy and he tells her, hey, you have a fatty liver. We don't have to do a biopsy to know that the woman has fatty liver. Fatty liver means that her insulin took all the carbohydrates, makes them into fat, and then deposits them into the liver. And when you do a blood test and you measure the liver enzymes, all of a sudden those liver enzymes are elevated. That's a big problem. We have to fix that because the liver is one thing that's very hard for us to replace. So if you take year after year, the liver gets inflamed, more and more inflamed. That's a huge problem. So what I try to do is I try to immediately get them to go on a low carbohydrate diet, get them some medication to lower their insulin. And little by little, we can actually reverse all that. We always can reverse all that within a month or two, just by diet and lowering their insulin. All those problems can be reversed, okay? And so we also know that metformin helps us. There's some big talk about it's not doing anything, and we combine it with Clomid, and you have to combine it with Clomid to really get an effect. But metformin does help. Anything that help us lower insulin, it does improve infertility. And we also know that when we use it with in vitro fertilization, we have less miscarriages, we have less hyperstimulation where the ovary keeps on growing, and there are more complications with IVF and PCOS. And then I also, there's a lot of good data that if you continue metformin when the individual is pregnant, then they'll have a less risk of developing diabetes when they're pregnant, and less risk of high blood pressure when they're pregnant. So there's some other good sides to metformin continuing it when a woman is undergoing a pregnancy. And the biggest part for us is if that woman's sugar wasn't so good before she was pregnant, well, lo and behold, when she's pregnant and she has PCOS, it's going to get much worse. It will always get much worse. Then all of a sudden the doctor says, hey, I'm sorry, ma'am, but you're going to have to use insulin. Well, imagine you're pregnant, you have to use insulin, and all of a sudden you're diabetic out of nowhere. So the best thing that I try to do is to try to get their sugar to be perfect before. And I keep saying, please lower your carbohydrates, please watch them. Do all the hard work before you conceive. So then once you conceive, you can be perfect. There's no reason for you not to be perfect, okay? So metformin also helps us get the cycle to be regular. And the reason is, as we talked about before, if a woman doesn't ovulate, there's no cycle. So one of the reasons she's not ovulating is testosterone is high. So if metformin can lower insulin, it will lower testosterone. When it lowers testosterone, the egg will start to grow and the woman will ovulate. So metformin can restore menstrual cycle, okay? But it doesn't really do a good job as lowering your weight. So a woman comes to me, she says, you know what? I know a friend of mine, she took PCOS, she lost 20 pounds, and you're giving it to me, and I barely lost a pound. Well, that's true. It doesn't do a good job for every single person. It doesn't work very well on every person. It does a different job on different individuals, okay? But it does help us lower cholesterol. It does help us with the triglycerides. It does do a good job lowering testosterone, and helps us a little bit on the other side, lowering those fats that insulin is making, the cholesterol and triglycerides. So it will lower the triglycerides. And that's very important to me, because if I see an 18-year-old and all of a sudden her cholesterol's high, triglycerides high, well, what's going to happen when she gets to her 50s? That's huge. Okay, so it does help me. And the big problem with metformin, as you all know probably, is the nausea and diarrhea. It's horrible for the GI tract. It's very common. We try to do different things, use it different ways. The extended release is Glumetza. Regardless of what I use, we can definitely have issues with digestion and diarrhea. And so it turns out that metformin is really more effective in women who have the insulin issue, but they're not obese. If a woman has overweight and you give her metformin, it probably won't work as well as you would like to. And those are the women that really wanted them to work, because they have more insulin resistance usually, and they're struggling with their weight. But it doesn't sometimes work very well on women who are overweight. And it turns out that the reason it doesn't work very well is because there's genetic variation. All of us don't have the same genetic makeup, and some people react well to metformin and some women don't. And that makes more sense, because I think it should work very well, but it doesn't. I often get surprised at how women, when they come back to me, patients don't do the same. Absolutely not. And that makes sense. Now we're learning that it's just genetic variation. And so the big part is this: we always struggle with the treatment, and part of the treatment is weight loss. Part of the treatment for PCOS is weight loss. Why? Because the extra weight that we carry around makes more insulin. That contributes to more testosterone. And it always worsens the symptoms. So when you lower the weight, you're actually improving your symptoms without taking any drugs. Okay? So weight loss is part of our treatment, including women who are not, who could be just a little overweight or not obese. Some weight loss can help them as well. And so diets are coming and going, but it turns out that the best part for our patients is to have, when they compare a low carbohydrate diet, like 41% carbohydrates, 19% protein, and 40% fat, that's much better than a 55% carbohydrates and 18% protein and 27% fat. Even if it did 1,800 or 2,500 calories, which is probably okay, and that's pretty reasonable for most of our patients. So when they used a lower carbohydrate diet, just lower carbohydrate, you don't have to go crazy, okay, what do I eat? I can't eat anything. Just lower the carbohydrates in your diet. It turns out that that's the best thing, or the best diet to treat some of the symptoms with PCOS, okay? And so they found a lot better effects of lowering testosterone, lowering insulin with lower carbohydrates were used, okay? Now, sorry, I'm gonna go back, did I skip over that? And so the lower carbohydrate diet had lower glucose, lower insulin, lower testosterone. And there's a big study that you probably, all of you know, and they had 7,000 patients, and they had them do a Mediterranean diet, which Mediterranean diet is not so bad. It's more olive oil, some wine, a lot of nuts, so it's but a little bit less carbohydrate because you're substituting nuts and other proteins. That diet actually really is I think it's a 5-year study, really lowered heart disease. So that's probably one of the best studies we've done in a long time, looking at so many people. It actually lowered the heart disease. So if you think about it, that really kind of makes sense to maybe say, okay, well, maybe this will be good for women with PCOS because they already are at risk of heart disease, high cholesterol, high insulin, heart disease. That may not be a bad idea to do, maybe a Mediterranean diet kind of thing with lower carbohydrates. That probably is the best thing. And then I think that Dr. Abuzi did a great job with this slide here. So I had to put it in because it's something that all of us doctors don't really talk about. But PCOS has 4 times higher risk of getting depression as any other disease. And that's huge because that depression can contribute to heart disease, okay? And so the higher the insulin, the more issues with their cycles, the more issues with hirsutism, the higher the depression. So we always try to fix some of those things so depression gets better. Okay. And then the American Heart, as far as exercise, if you do just a minimum of 30 minutes, 3 times a week, try to lower the insulin with a low carbohydrate diet. Yeah, that's going to do a lot. That's going to really do a lot. And like any diet, you got to have some kind of psychological intervention. You can't just, a lot of times it's very hard to do it on your own. So if you can get a friend or a partner to do it with you, get a trainer, it's much, much better than try to struggle with it by yourself. And so recently, insulin brings the sugar into the cell by a second messenger called an acetylphosphoglycan. And it turns out that women with PCOS lack that messenger. They just don't have it. They don't have it. And this messenger is made up of docaranositol, we call it DCI. But the precursor of it is myoinositol, so you may have heard of myoinositol. But really it's docaranositol that's lacking in women with PCOS. And it turns out that they don't have it, and maybe that's why insulin's not working very well. Okay? They have some of it, but it's not working so well. And so myoinositol is like you find it in many foods. It's like in the B vitamins, okay? And you found it in citrus fruit, leafy vegetables, almonds, walnuts. The docaranositol is what myo-inositol gets converted to is found in some plants, fruits, like buckwheat and carob. Carob is kind of interesting because that's also part of the Mediterranean diet. So when you take myo-inositol from the food, a lot of it is found in the food, from the B vitamins. It's a vitamin, basically. It gets converted to Dakar-inositol in our tissue. And it's the Dakar-inositol that helps insulin bring the sugar into the cell. So it's a Dakar-inositol that we want to try to supplement. And so the myo-inositol, if you look at all the things it does, it's important for reproduction, increasing the egg quality, it's important to, it lowers insulin, it's good for the bone, it's good for the nervous system, it's good for mood. So a lot of this you see really is kind of some of the things we've been talking about, okay? They kind of, it makes sense. Well, maybe we need more of this, okay? And so I typically give 1,200 milligrams of Dakar-inositol, and it looks like it really improve insulin resistance. And so even people think the studies were done, metformin actually works lowering insulin by increasing the Dakar-inositol level. So we think that's probably one of the ways that metformin is working. It increases Dakar-inositol level, okay? And it was found to be even more effective in women who are obese. Well, that makes more sense. Maybe if metformin doesn't work for them, I'll just probably give them Dakar-inositol. And then it's definitely been shown, many studies now, that it decreases testosterone, it decreases cholesterol. 86% of women ovulate on Dakar-inositol, and it also helped with their weight. And that's great. I mean, if I have something like this that has no side effects and it's like a vitamin, because basically it's like a vitamin, well, that's even better than just taking any drugs, and you could probably take it long term and it won't do any side effects. And so I've been trying to use more and more Dakar-inositol. I think it's helpful, and many of my patients have no issues. And so I wanted to address this one thing that we keep worrying about. Does PCOS increase cancer? Well, it definitely increases the risk of uterine cancer. A lot of times women don't ovulate, they don't get a cycle. All that estrogen that is being made is turning all the glands inside the uterus, turning them around to become more and more, to become irregular, atypical, and that can increase cancer. So we always stress to our women, hey, just like she was saying, we would like them to have a cycle unless they're pregnant or they're on birth control pill. Those are the two times women do not have to have a regular cycle, or we look for them to have a regular cycle. All the other times we really like to have them have a regular cycle because we want them to shed off that lining. That lining doesn't need to be in there, staying there and growing and making cancer, okay? And insulin makes it even worse. The testosterone makes it worse. But if you take a birth control pill, well, it helps because it helps getting a cycle back, and it also will reduce the risk of uterine cancer by 50%. Okay, so birth control pills are very good for us. And so ovarian cancer is one thing we worry about because, yes, there's definitely increase in ovarian cancer in women with PCOS. Instead of 17 per 10,000, it'll go up to 44 per 10,000. That's more than double. Birth control pill use, even use as little as 1 to 5 years, does help us reduce the risk of ovarian cancer. So that's another good thing. Okay, if you have a family history, well, we need to really focus on this. And the last thing, the good thing is, people were worried about breast cancer. They thought, well, maybe it's higher in women with PCOS, so it's not. But it turns out that more and more data has come in that it's not. Breast cancer is not increased in women with PCOS, mostly just uterine and ovarian. Okay. And so in conclusion, basically, how do we put all this together? What do we do now? So we gotta lower insulin somehow. Okay, we can lower it with metformin, we can lower it with Dakar-inositol, we can lower it with diet, exercise. All those are good things to help us lower insulin. That will help us lower testosterone. That will get the cycles back to normal. That will increase fertility. That will lower the risk of heart disease and so forth, cholesterol. And then birth control pills are they've always stayed the same. And then people tell me, well, look, I don't really want to use the pill. Just give me something to just get my cycle. So I just give them progesterone once a month to get their cycle. But in a way, birth control pill is not a bad thing. People always say, oh, I don't want the pill. I wanna have my fertility. If you use it for 5 years, 6 years, or whatever you use it, it doesn't turn out to be any disadvantage to you conceiving later. It doesn't make you infertile. It doesn't have long-term effects that we know of. Okay, so I hope that helps, and I think we're going to have breakout session if you have any questions for me.